Well, as people continue to join, I'm going to just go ahead and start with some of our introductions. We've got a lot of fun stuff to talk about. Dr. Durrie, this introduction will be mostly for you because a lot of the folks that I see here already have been on previous sessions, but boy, it was probably a couple of years ago when we started to have this idea at MJM, our marketing company, because we're getting so many questions from practices that we should just start a regularly occurring admin meeting of how to implement all this great technology. We get so many calls with people who have a new laser that's on a loading dock, or there's a new procedure that's coming in that they don't know how to bill insurance for. And the administrator underground has to get together to figure out, okay, so now how are we going to implement this? And I have to tell you, it really starts with Vance for me, but Vance always says that there's nobody better at introducing and implementing new technology than you. And of course, you're one of his primary mentors in his career. And so that means that you've, by way of proxy, been a good mentor of mine. I remember being a part of Vance Thompson Vision for only a few weeks when I came down and visited you, and we went to a nice dinner together afterwards. And you were talking to me even then. This is now 23 years ago of how to do a better job of explaining some of the life benefits of LASIK at the time and what was coming down the road with premium IOLs. But I'm excited that you're here with us today, Dr. Durrie, and because we're talking about something that I think we both agree should be much, much better, which is adoption to premium in cataract surgery, but really in refractive as well, how to have that difficult conversation. And while I've called this title "Getting to Yes," it's really about building the premium practice, as you've taught me over the years. And so, one, I want to thank you for joining us. Two, just so you know, I'm going to ask Steve and Amy and Stephanie and Lisa and others who join us, Rachel included, to unmute as they have questions and just interrupt us. We want this to be as back and forth as possible, and we'll talk for, I don't know, 20 or 30 minutes if there's no interruptions, and then get to their questions. And usually this runs 45 minutes to an hour in total, and people will be left with hopefully some things that they can use to implement on Monday. Now, that's a very careless introduction to you, Dr. Durrie. You've been doing this. I mean, you were part of every real innovation in ophthalmology, from some of the mini incision cataract surgery to some of the obviously the refractive IOLs, phaco and others, and of course the LASIK world as well when Vance did his fellowship there. So first of all, thanks for joining us and give us a sense of the building of the premium practice, and feel free to defend yourself also with my introduction.
Okay, thank you, Matt. Thank you, Rachel. And this is fun. And for anybody who's joining, certainly make it interactive. I would like that to interrupt me or throw out questions or Rachel, are you going to monitor the chat if they put anything on that?
Definitely.
Okay, so one thing I thought about in this Thursdays at 3 when I had the privilege of being invited to do this, I wanted to talk about the premium practice itself, not technology and not a lot of the things that we discuss at meetings, but really the premium practice. And one thing that's kind of shocked people when I tell them this, and that Durrie Vision, which has my name on it, and even though I retired a few years ago, it's still going strong with everything we built at that point in time. But I started it at age 53. And that kind of blows people away. And I think anybody who's that age or younger has all the things to do, because it ended up being that we decided in 2002 to become a premium practice. And
Hmm.
that was the decision. We just had to make a decision to do that. And at that point in time, before that, I was just this kind of a standard cataract LASIK practice with a large group, but I had my own practice. Said, what are we going to do differently? We became a premium practice. So I'd like to go back and forth, and anybody have questions, kind of have that be the focus of what would I suggest from my past experience and working with a lot of practice and teaching a lot of fellows. So what does that really mean? And I'll start with just kind of a simple one is does your practice itself, when you come in the door and even when you park in the parking lot and you come into the practice, does it look like a premium practice? What does the patient see? And sometimes you have to go outside of your group and ask somebody, if you have you could have your wife or significant other come in and say, what do you see? And then my wife kind of did that for us when we started the practice. And then she would do it in the exam room, in the testing room, and everything else, and come back and say, that looks terrible there.
Hmm.
You did this and it looks junky. It doesn't look premium. And these are things, it doesn't cost anything to do this. There's something that just kind of look, and the staff loves it. It says, okay, we're going to really make a premium effort here. Let's all work together to make it our appearance premium. The coffee's got to be good. And if, a lot of people serve warm chocolate chip cookies in the waiting room, which smells good for everybody, and do that. So does it look like a premium practice? And it really sets you up for later on as the patient goes through it and has this experience that once you ask for the sale or ask them to pay a premium price or take you over somebody else in the community, you've set that up for them at that point in time.
Maybe I'll just add something to that, Dr. Durrie. In the old days, we were asking for, $2,500 to $3,000 per eye for vision correction.
Mhm.
And I know I even learned it from you because I wore a suit and tie to your practice. I don't know if you remember this story, to observe you. And you asked me if I did that every day, and I said I don't. And you said, well, you should. and 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 because it kind of commands a certain like but now with premium IOLs, it's more like 10 to 12 grand bilaterally, and it's worth dressing up for.
Yeah, and it's the other thing too. And back in the LASIK days when we were kind of deciding what was the premium price for LASIK, I used to ask my staff and say, this is back when we were charging, I think, $2,800 for per eye for LASIK surgery, which was the highest in the community. I'd ask the staff, what does a $3,500 an eye LASIK look like? What is the
Hmm.
experience for something above that? And right now, I'd say, what does the $15,000 bilateral IOL look like to the patient? So then you got to go, oh, and well, probably not what I'm doing right now from that standpoint, because one of marketing 101 is differentiation, and the best way to differentiate yourself on pricing is at the top because that's where there's the fewest people there, and then you get to show that. So appearance in the practice. The other one, which is kind of a big one for me, is really staff training and consistency. In our practices and several of the other practices that I've helped you, we put in a words matter program. What that really means from the staff standpoint is when a patient has a question or even the staff has a question, we all answer the question the same because we use the same language. So specifically, like we never use the term monovision. We use blended vision because monovision sounds terrible to a patient, and blended vision means the eyes blend together. And that's like stereo music, the speakers and sound blends together. So we have a rule, nobody says monovision, and then people will correct somebody if they use that term. Not mini monovision, that sounds even worse than monovision. So those are things that we have a list of words like that. And we don't talk about nuclear sclerosis. We don't talk about cortical lens changes. We don't talk about posterior subcapsular cataracts. We talk about dysfunctional lens syndrome, stage 1, 2, and 3. And everybody in the practice knows it, from the front desk, from the people on the phone, from the marketing people and everything else, know that that is the language that you use. And so when somebody comes in, even if it's a teenager having LASIK and they say, how long is this going to last? And I tell them about dysfunctional lens syndrome and the stages of their lens that are going to happen after the LASIK surgery. So we get real consistency on that.
Yeah,
Um,
I'm going to draw that out just a minute if you don't mind, Dr. Durrie, because that's a really important kind of stake in the ground that helps your entire team understand the entire refractive journey. If you don't mind, can you break it down into those basically the three stages of dysfunctional lens syndrome?
Yeah, and I'll do it in two ways.
Okay.
Um, First, the lens in the eye, as we know, is a continuum of change. You know, the cornea doesn't change very much the whole life. That's the fixed focus lens in the eye. But the other one, but most of our patients don't even know they have a second lens in the eye, and they don't know it changes every single year. The lens actually has its highest focusing power at age 13. That's when we have the most focusing. Lack of accommodation starts at 13, and then
Mm.
eventually our arms get too short in the 40s. And that is stage one of DLS, dysfunctional lens syndrome. The first stage, stage one DLS, is when your arms get too short and you're feeling like you're grabbing reading glasses to read, and that's in your 40s. And I don't get too specific, I just say in your 40s. And then once they kind of head nod, then I kind of go, and then stage two is in your 50s and 60s. And that's when the lens starts getting yellow and hazy, and that's stage two of DLS. And then, so that replaces the words like nuclear sclerosis or corneal lens changes or PSC and those things, or early cataract. We don't use those. And then stage three is a cataract,
Hmm.
a billable cataract. And if you said that to patients, what they do is they go, does everybody get a cataract? And I say, yeah, if you live long enough. Oh, and they said, is there anything you can do about it? Yes. When you get in your 40s and 50s, we can replace your lens and prevent cataracts. And they look at me like, that's a great piece of news. I didn't know that was a possibility. So even if somebody is 40 and in stage one, you've already set them up for being a patient for you for a premium lens down the road. The other part about that is that, and this has been in the Words Matter program, there's only two kinds of cataract surgery. There is basic cataract surgery, and that word's important, the basic, because people don't want basic anything, and they want to go, don't want to go to basic training, and they don't want the basic thing or the government issue, but just call it basic. And the other one is refractive cataract surgery. And that doesn't make any difference whether you have a cataract or not. It's, you know, you can prevent cataracts with refractive cataract surgery. And then I say there's two things that are different about that. Number one, our goal is different because we're trying to get you near and distance vision without glasses. And you have to pay for it. And I say that up front. There's two differences. And nobody ever objects to paying for something that's the premium thing.
Yeah.
And we've got that out there right there. So I address that, and all the staff knows it. Like I said, all the way to the counselors. I went and visited practice, which really kind of nailed this. I had a practice that was doing a lot of cataract surgery. They were a good practice, and but they were doing almost no premium, even though they had invested in everything and they'd done the training and they marketed for it. And I found out as I followed a patient through, everybody said a different thing to the patient in answer to the same question. And eventually, I was with the little lady and her husband, and she'd been addressed with premium. She said, "I'm so confused. I'm just going to do that ordinary cataract surgery. I'll sign up for that." So the practice talked them out of it by not using the same language. So that's a fairly strong point in that. But that's the language of that. And there's quite a few things. If you go out there and look at the Words Matter programs and searched it, even if you went to ChatGPT or your favorite generative AI and said, "Tell me about the dysfunctional lens syndrome," it's going to give you all that stuff in stage one, two, and three. It's already out there in the real world. We just need to take it to our staff and patients.
And make it consistent. I want to, there's a couple of things in there that are just really important morsels for people to know as they turn around and talk with their team about this, Dr. Durrie. One is using the word basic. Okay.
Mhm.
And that's really important because sometimes we're tempted to say, well, that's standard cataract surgery, or it's the monofocal based cataract surgery. A couple of things. First of all, nobody understands what monofocal means. Two,
Mhm.
to say it's standard, people will assume that it's the standard of care, but it's not. The standard of care is the aspirational standard that's set by those at the very leading edge of a category. And while there are some great basic cataract surgery lenses, better than they've ever been, it's not as pristine and they don't offer the refractive outcomes that all of the higher end lenses do. And so
Hmm.
refractive and basic are the really important things. And the last part is you mentioned that, the one that's the more expensive, the refractive, people understand that they have to pay out of pocket for that. The other
Hmm.
thing to just maybe mention to your team is it doesn't matter whether they're talking about the refractive lens or the refractive cataract surgery or even just the basic cataract surgery. More than likely, patients are paying a large amount over out of pocket for it because of how insurance works today. And so if you're selling basic cataract surgery in that it it's not out of pocket, you're probably misleading the patient to where 30 days down the road they're going to be bummed because there's still an outstanding coinsurance deductible, et cetera, that's due. And they may as well have that they would probably think to themselves, boy, I should have just gone a couple extra $1,000. I'm paying a couple $1,000 anyway. And so I
Yeah,
think that's important discussion for the team.
yeah, and another thing, and this kind of shocks people, but this works unbelievably well. If you want to be a premium practice in Durrie Vision, if somebody came and says, "I just want to have that basic cataract surgery my insurance will cover," we refer them to somebody else.
Hmm.
We are premium practice. We do premium cataract surgery, and nobody goes. As soon as I say that, I've got a great one of my old partners here that I can send you to, and they take your insurance and they do that basic cataract surgery. I've never have anybody leave the practice. They all just bump right over to premium, but you got to stick with it. And,
Hmm.
if we do that. Now, we do a lot of free surgery for people with disabilities and stuff. And so we're not, we do free surgery for people, but we're a premium practice. So we don't have, our fellows do cheap surgery or anything else. They do the same premium surgeries that we do. So I think that shows you how strong it is. And that's another words matter. Boy, when you tell somebody that you're willing to send them to somebody else because they're not willing to step up to premium, um, that's just not going to happen. They're going to stay with you, or maybe if they can't afford it right now, they might come back later. You know, uh,
I really like that you distinguished that point because while you and I know that you've got the practice that's completely dedicated to refractive, maybe some of our listeners don't know that that's a decision that your practice made, right?
Yeah, that's a premium practice. Everything we did is premium. And then so also the financing gets easier because everybody's going to pay a premium price.
Hmm.
Some of them that have a billable cataract are going to have some of the facility paid for and some of the procedures paid for. Um, Now, one thing that I'd like to point out to people that when I started Durrie Vision, we didn't take any insurance or Medicare. Okay, so we were totally private pay and no insurance, no Medicare. I don't advise that anymore because we did a lot of research on that, and 30% of your patients will not come in to see you if you don't take their insurance and Medicare. So we just use that as a marketing plan. It's the hassle of the billing that we didn't have back when we were totally premium. But you can use that, but that doesn't mean you have to do basic cataract surgery. You can do premium cataract surgery and participate with insurance and Medicare. Okay, but you still don't have to do things that aren't premium. So that's kind of an interesting thing that's changed since we started a practice. Is we now Durrie Vision now takes insurance and Medicare because they want those patients to come in so we can talk about the three stages of DLS and the premium options that we have with that. So that's kind of a neat thing.
That's great. So to recap the stage or the components of becoming a premium practice is you have to review kind of how you look and feel, right? You have to have a commitment to how you talk about DLS, dysfunctional lens syndrome. You have to have a commitment to words matter and how you train and communicate with your team, and then how they communicate with your shared patients. Um, what else?
Well, I think that the other thing too with this is really neat now because there's a lot of premium practices now, and they follow what I just told you. Even the people that train with me or the people that it's a whole new generation. Go visit those practices and take one of your lead people along and just kind of shadow them It's very inexpensive to pay a hotel room and a airplane ticket rather than buying a new machine or a topography machine. All the things I'm going to give you today are inexpensive to do. So go and visit a premium practice, and don't be afraid to visit the one that's competition in your town. They will be surprised that you invited them, but they won't say don't come. You just
Mm.
and it's good camaraderie. But or something a few minutes down the road is fine too. But go visit a premium practice, and the whole purpose is to see what makes them premium. And just remember, if they're not doing 70 to 80% of premium or up to 100% like Durrie Vision, you don't go there. You don't go
Hmm.
to somebody who's doing 20% premium upgrades, quote unquote,
Hmm.
because they're not there yet. So pick your practices on people that are doing that level, and there's hundreds of them now, and they like to share and they like to show off because they're very proud of what they're doing.
Now, Dr. Drury, as we transition to the next set of questions here, I just want to ask our listeners, Steve, Stephanie, Lisa, Amy, any questions for Dr. Drury as we leave the topic of becoming a premium practice and go towards how to talk to patients? Okay. Well, let's move on then, and I'm going to just jump around here in these PowerPoints because I want to talk about this lifetime vision assessment first, and that'll transition Dr. Dury into the topic of how you make the recommendation, how the provider should make a recommendation. So tell me about the lifetime vision assessment, and then transition that into how you talk to the patient, how you coach doctors to talk to the patient.
Yeah, I think that one thing, and this goes back to when we started Duravision in 2002, we were a catch and release practice. We were bring the person in, do their cataract or the LASIK, and send them out of the practice. So we were a catch and release practice. And then all of a sudden we realized we wanted these patients to come back into our practice because they all had lenses in their eyes that we wanted to take out at some point in time and give them a premium IOL. So we figured we had to kind of have a hook, so to speak, and we formed a lifetime vision exam. We called it an advanced ocular analysis, AOA, and that's a lot of people are using that term now. But the purpose of it was to give them a lifetime vision assessment. Because a lot of people, when they come in, whether it's a LASIK patient or a cataract patient, they want to know what's going to happen after I'm done with you or after I'm done with this surgery. So I'll give you a little bit of speech how I come into. If somebody comes in to see me, and it doesn't make any difference whether it's a cataract patient or somebody that's a minus 12 for a phakic IOL or a LASIK patient, I'd say today we're going to do your lifetime vision plan. And in that, we're going to decide whether the best way for vision for you is glasses, contact lenses, or is it surgery? And then I say, and this is important, and if you're not a good surgical candidate, we'll know that today, and then we'll make sure your glasses and contacts work the best for you. That's really key because all of a sudden you don't look like you're just selling surgery, and you don't look like everybody gets through your training there. And the other thing that I say with that is nowadays there's 7 different types of vision correction procedures. And this assessment today will tell you which one is the right one for you. And you won't get multiple choice at the end of the examination. There is a right procedure for you, and I'll let you know what it is. Many surgeons just love to give people options. They don't they don't come in looking for options. They're looking for vision correction, and you're the expert. You need to tell them what it is, and at that point in time, I'm not going to, if they're say they're 55 years old in stage 2 of DLS, and we're going to do a custom lens replacement, which is the best term we've used now for RLE is custom lens replacement. That's the one we use. Is if we're going to do that, I don't talk about what kind of IOL they're going to have. I don't talk about whether they're going to get an LAL or a multifocal or I'm just saying, are you in that category? And send it, and once they sign up, then I'll pick the lens that's the best for them. I mean, and make it easy. Don't give them a bunch of options. So recommending, because you think about it, if you go in for other services, other medical services or something to fix your car, you don't want the mechanic come up here and say, there's 3 or 4 options I could do to kind of fix your problem. They come up and say, this is what you need. And for some reason, our basic kind of the way we're trained, we have a tendency, we got to tell people all the options. Well, they really want to know which one's the best one for them. So that's part of the Words Matter program is we come up and we make a recommendation. And while I'm doing the lifetime vision plan, say I have somebody that's let's say they're a LASIK patient and they're a -6. I kind of know that from the refraction. I'm going along and I'm doing their life vision. I find out they have a 480 micron cornea. I'm not going to talk to them about LASIK or SMILE. I'm going to talk to them about phakic IOLs, and that's what they're a candidate for. And I'm not going to tell them you could be a candidate this, but your cornea is thin and da 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 da. You just kind of say, good news, you are a candidate. That's our conclusion. And this is the best procedure you. Matter of fact, it's custom made for you. And that really gives them a strong message that this is the right procedure for them. And I don't really put SMILE and LASIK in a different category. They're kind of the same category, and it's done with a laser. PRK, you do that when they have poor epithelium or there's a reason to do that, on that part. But I think the
Well, and that's
big
kind of the
one,
difference between corneal refractive surgery, right?
yep.
Implant refractive surgery or lenticular refractive surgery.
Yeah, and I think that I tell this to a lot of people now, so it's fun kind of discussing in a group like this. If you're looking at leading your community in something, it's really hard in any community out there when you're established, like many of you are, to be the lead cataract surgeon because that place is already taken. And usually there's 3 or 4 of them that are older than you are, and they've been doing it forever, and they have the OD networks and everything else. So the cataract position is kind of taken. If you look at the lead LASIK practice, that's kind of hard too, because we even have the corporate entities that are competition to us. But if you were going to be the lead presbyopic surgery surgeon or the lead lens replacement surgery or the lead premium lens, that's wide open within your community. Nobody's even talking about it. And I mentioned it once before, and this is in the Words Matter thing, is when you replace somebody's lens, you prevent cataracts. I mean, it's just a fact. And the patient says, wow, you mean I didn't know you could prevent cataracts? Yeah. I mean, you can do that if we replace your lens, it's going to stop the aging in your lens. And that's pretty cool. And,
Yeah, we caught it before it got cloudy.
yeah. And even if it's starting to get cloudy, because if you're in stage 2 of DLS, that's the difference. Because a lot of people would talk about clear lens extraction. Well, I already told you the lens after age 13 is dysfunctional. It's going downhill, and especially at age 40 and or 50 and 60, it's yellow. They've lost their contrast sensitivity. It is not clear in any way, shape, or form, and it can't accommodate. So it's dysfunctional, and in that stage, it's in stage 2. So using those terms really makes a difference. Back to that little speech about DLS stage 1, 2, and 3. When I explained stage 1, your arm's getting shorter and the lens getting harder. Stage 2, yellow, losing your contrast sensitivity, your night vision's not as good. And then I say, and stage 3 is a cataract. And then I have this pregnant pause. I don't say anything for a little while. And then they look at me and then they do those 2 questions. Does everybody get cataract? Yes, if you live long enough. Is there anything you could do about it? Yes, there is. So by having them, they don't want a cataract, if they're at that stage. And so it's an interesting way to kind of control the conversation is by just pausing and letting them interact to that. So that's a little bit this kind of the speech and the other things. That's what's good about visiting practices. The other thing, and Matt, you're very involved in this in many ways, and I am too, is there's now quite a few programs going on to teach you how to be a premium practice. ASCRS has just really stepped up under Vance Thompson's direction and come up with the BRICS program. And these are things that are really neat now because they're focused on that. And the other one is the Outliers program. The Outliers program doesn't talk about any technology. It just talks about customer service. And I think, Matt, you're going to be involved in the next one of those. It's like I've been involved in all of them. And it's really cool because it's all practices trying to share about how to be a premium practice. And again, very little expense from this standpoint compared to us. You know, it's a lot cheaper than buying a topography machine. So that's kind
Mhm.
of our thing we compare everything to. And we our practices like to buy stuff, but learning is a lot cheaper and a lot more valuable from that standpoint.
Well, and that's what these whole sessions are for, is not just you've got the technology now, how do you implement it, right? And whether that's new lasers for cataract surgery, the femtosecond lasers, or whether it's the light delivery device, for the light adjustable lens. And I put this slide up here. It was towards the end of our conversation, or at least our prepared deck, Dr. Durrie, of the upcoming sessions we have, the business of refractive cataract surgery. That's going to be done the first weekend in October in Chicago. That's going to be very well attended. Registrations are already exciting. And then we're doing the same thing in interventional glaucoma, which is a totally different bent. It's not elective, but it is talking about kind of a righteous thing to do for our patients who are kind of despairing and not taking their drops like they should. And we need to do something better as an industry and getting in front of them and really arresting the progression of their disease. And so the implementation of that is also tricky. So that's going to be in conjunction with the academy meeting um, the Thursday before. So both of those are um, worth coming alongside and learning from. A lot of people bring their teams as well. I want to draw your attention really quickly to a question that came in from Stephanie from Tally Eye Institute. Thanks, Stephanie, for this. But she wanted to know, how do you rely, or how much do you rely on pre-education for patients? And what did it look like in your practice? I can answer for myself, but I'll go to you first, Dr. Durrie.
Actually, I've we were fortunate that I'm in Kansas, and the Kansas University Business MBA program used our practice as a full semester with 6 people in our practice that watched everything. And they found out that by far the most valuable thing was the face-to-face after testing with the doctor. And a lot of times I think people do pre-education sometimes because they don't want to do the education face to face themselves. They kind of say, I'm going to put a video in the waiting room or I'm going to send it stuff. Now there are some good things out that kind of prepare people about that there are different kind of IOLs. Certainly all the companies put them out and several of the really good marketing people put things out, but there's no substitute whatsoever. And what was neat about this MDA program is they came back to us and they looked at the willingness to buy at every step all the way along the practice with thousands of patients and found out. Then they came back to me and said, you need to spend 18 minutes with the patient. They told us very specific. It said, and that's where you're going to get your highest return if you, the surgeon, spend 18 minutes with patients. So all of a sudden, we had to change our schedule around so that we could have enough time for the doctor to spend 18 minutes. And so another thing we did, this relates back to number one, is we got rid of the waiting room. Why do people hate going to the doctor? They hate giving a clipboard and sit down. So we met them at the desk, and the waiting room was still there for the staff or the family that wanted to sit there. But we never had the patient sit down. We met them in front of the desk and brought them back and started doing their history and their testing and everything. And it worked unbelievably well. As people would say, you got to go to Durrie Vision. They don't even ever let you have to sit down in the waiting room. So those are things that you can, and that came from a suggestion from our staff. just because when we were becoming a premium practice, what we could do. And everybody says, well, I can't, I went to the doctor the other day and had to sit half an hour in there and fill out all the paperwork. So we just did away with it. And then the staff figured out how to do that. How do we do the flow? How did it work from there? So that was a neat little challenge.
Well, and they'll gladly do the work as long as they know everybody's committed to it, right? Waiting rooms have become just a place to hold patients in inventory when
Hmm.
we want them to keep moving along. I like that you referenced also what you learned, that the doctor's recommendation is the most important in the continuum. And yet, that is to the exclusion of everything else. Ideally, we let them know about the really important decision that they're going to need to make at every stage of, at every touch point, from their referring doctor to the information they get before they come in, whether that's text or brochure or ideally both. Their reminder call. Hey, we want to make sure that you reviewed that information from Dr. Durrie. He created it just for you. Make sure you watch or read that before you come in tomorrow. And by the way, are you coming in with a driver or a loved one? We'd really like them to hear about the options as well, because they can offer you some advice, and you need a driver anyway. You just kind of you're giving them a little dose of something is coming at each step of the process.
I think the good thing about that, Matt, is you added it on to what I said, but do not replace that stuff with you talking to the patient. So if you only did one of them and didn't do any brochures or anything else, that's the one that's the most important. And
That's right.
everything you add on that builds on it because I see too many people who kind of delegate things to a video out in the waiting room or a brochure or something that they got ahead of time. But they don't talk to the patient and their conversion rates are terrible.
Well, and the thing is with all the practices like yours that are doing so well, right? Um, we're still as an industry only doing 12 to 14% adoption, and that includes, femto and otherwise. And
Mhm.
so just imagine, and that's with patients hearing most of them from the doctor only. Imagine if we touched them way beforehand and everybody committed to still having that important doctor conversation. It'd be where I think it should be, which is in the, you know, across the board, insurance and otherwise, 30 to 40%.
Yeah, you think that, and you also have to set a little target. Like I said, if you're going to go visit a practice, do one that's doing 70, 80% premium. But also in your own, I've had a couple of practices I work with that weren't doing any premium, and we went to 40% premium the next month. I mean, just because we did the words matter and lunch and learns and all that stuff. I mean, you can do it. It's just that you've got to commit to it. And then your target should be to be like the real premium practices that are up in the 80 or 90%. And you can do it because all the surveys, and they've been done by all of our major suppliers, Alcon, J&J and such. 82% of people, if you ask them, are they willing to pay with the prices we're charging for having better vision long term? Are you willing to do that? 82% of them would say yes. How can we be stuck in the teens on this? It's all at the practice level that we are the bottleneck. We're not willing to ask, and we're not being willing to be premium enough, so to speak, in order to do that. And so I think that's important. One thing, and I do want to get kind of into any Q&As, and you're good with this, Matt. So I think with Stephanie and Amy, the people on that, are if they don't ask questions, I'll ask them questions. So, uh, but the other thing that you really do, which is the biggest feel good for your staff's the most important thing out there, is how can you be the practice that's recognized by your staff and even your spouse and everybody in the community as giving back to the community? This is a big thing that I'm into now, kind of towards the tail end of my career, is we've been very fortunate in cataract surgery and in ophthalmology in general, giving this premium gift. And it's good for our patients, good for our practice, good for our bottom line, but we haven't been very good about giving back in the premium surgery area. There is a new foundation. I was one of the founding members called the Visual Freedom Foundation, who's taking care of the poorest of the poor worldwide. And a lot of programs are putting in something, though everybody that comes in and does premium cataract surgery, X number of dollars, maybe a couple $100 are donated to so somebody in India can have cataract surgery. And people just eat that up. And well, you just go ahead and raise your price by whatever you're given that there, and they're still going to buy it. It's just that you're providing that service through you. The other one, which I started over 20 years ago, is taking care of the people who can't move their hands and arms. There's 150,000 quadriplegic patients in the United States, and any of them that are presbyopic, they can't put the reading glasses on and off. We should be doing refractive lens exchange on those patients. And that's something called Focus on Independence, and that's available. So those type of things, it's marvelous how your staff really loves it if you will give back to the community. Another thing that Vance Thompson did, and Matt, I'm sure you had a lot to do with this too, is he set up a program so every staff member had the ability to give free surgery to somebody in the community, whether it was at their church or anything else. And that made the staff right. That was part of one of Vance's and yours brilliant moves. And it tied everybody that we care. So the things that, we talked about appearance, we talked about the word matter, we talked about being premium, but also you should be a practice that is recognized by everybody around that's willing to give back. And if you do some work like with Susan McDonald in Tanzania or something like that, make sure that you get credit for it. One thing about it, when I started Focus on Independence, I was very leery about getting any press for it or anything else because I didn't want it to be about us. And I was totally wrong. And then I started inviting the press in, and then all the quadriplegic patients came to me. And also it helped everybody else. And my staff liked being on television. So it was kind of cool. But those are some things that you can do that you might not have thought about.
Well, and it's a great way to make your team more resilient to being recruited to another place. It's a big cultural win when you're giving back to the community in that fashion.
Yeah, no, that's for sure. And I think that now one thing I think I told you I wasn't going to talk about technology, but the one thing that I've found lately is I think you all know about light adjustable lenses. I've been a consultant for them forever. And light adjustable lenses are very interesting because I had one in my dominant eye and I'm 2010. I had one adjustment and I'm just perfect. And I can't imagine at age 76, I would be 2010 and never need anything else done. But what I found out from working with practices on this for a lot of years is a lot of people go out and get into the technology, but they don't really do it the way we did in the clinical trials. I ran 2 clinical trial centers on this. And we were very specific about treating dry eyes. We were very specific about stabilizing refractions. And what I'm seeing is people, because of the postoperative vision requirements, they're trying to short circuit them by treating people too early. They're not stabilized enough. You absolutely, in all of our premium IOLs, should treat dry eyes intensely. And wherever, whether it's multifocal, light adjustable, or anything else, you have to make sure their tear film is good, especially in the first 6 weeks, or they're going to complain about your surgery and your IOL and even out on the internet and start bad mouthing you. And all you didn't do is give them very specifics about how often you use the drops. And there's a lot of published literature from the Drew's 3 group that came out on which supplements actually work and have scientific evidence. So treating dry eyes and being patient. Like when I had my adjustment and, my Jason Stahl, my son-in-law, was doing the surgery, so we were deciding about it. We decided to, when I came back at a month, should we do a treatment? And we said, I'm not quite sure. We should not wait a little bit longer. And then we waited and I didn't need another adjustment. And then I just got locked in just because we waited. And I think a lot of people kind of rush in and do one treatment and 5 days later do another treatment. So I think there's some neat things with this. I like the technology, but you got to do it right. And I think that when I monitor the chat lines and stuff, then people are saying, patients didn't get a good results they expected. I don't think they're doing it the way they're supposed to be doing it. And you got to get serious about these. And anything that helps with technology and advance applies to all IOLs, treating dry eyes, both pre-op, intra-op, post-op, and everything you can do, because we put a lot of toxic drops in their eyes and tell them to use their drops afterwards that have preservatives in them. So you really got to treat dry eyes to be a premium practice.
Well, and same is true for laser based corneal procedures as well.
Mhm.
Attending to that surface is really, really important. And I've heard you and Vance both talk about that a lot of late. The other, it's I continue to hear the same thing you did, and that's and the and thankfully I'm hearing more and more that doctors are saying, listen, there's really no reason to rush the adjustments. I mean, it's the main benefit of this technology is you can adjust it afterwards. So let's not remove that benefit by trying to rush it. Let things settle in, attend to the tear film, get a great refractive outcome, do an assessment. And that's why, by the way, there's a nice little guide that's been created as well that you can walk patients through. Okay, so for the next couple of weeks, we want you to go around and enjoy your life, but use your vision to, check on this, pay attention to this. And we're kind of prescribing that time now on how they can best then customize their vision based on their liking. And I think that's really important.
Think about it. Let's play. Matt, you're the patient, I'm the doctor. You've had an LAL, and you come back to me, and it's time for me to decide to do an adjustment. I do a test on you and say, Matt, you're doing great, but I'd like to wait a little longer. I don't mind doing another exam on you, but I know you got to wear those funky glasses, but I'm willing to put in the extra time to get your results the best. What message did I send to you as a patient?
Well, you told me basically you're most concerned about my best interest.
Absolutely.
And you
Absolutely.
did reference really the only pain point, and that's the glasses, which aren't a real pain point. I mean, I've heard patients say something like this back to our doctors. Well, with as many people as I think are coming back here because I'm telling them how much I love my vision, and these glasses are like a billboard for you. Hopefully, you can use me in an ad or something like that in the future. But I mean, it doesn't bother them.
Yeah, it's interesting because my LAL glasses, those are the ones that I use to take a walk. You know, they're something I used, but I think you're exactly right. And the other thing about the sunglasses is that you want them to wear them outside. But I think they overemphasize too much. And so what I did is I just had one of those things that you wear on the boat where you hang your sunglasses around your neck when you're on the boat and out sailing. And I just put that on in the morning. And when I went outside, I put my sunglasses on. If not, I put it down there and it was just with me and it was super easy. And people say they didn't know what was going on. And I was wearing sunglasses outside and had them hung around my neck inside. And I mean, and yeah, and it happened to say Durrie Vision on the side. So, I mean, there wasn't anything wrong with wearing that and advertising a little bit.
Yeah, I love that. I've got a small group of guys, businessmen I meet with every other week or so, and there was a new one in the bunch, and he showed up with the glasses on, and it was so fun for me to hear him explain why he's wearing them, what's going on with them, and how on point I know the team must have been because they gave him the words to say to others, and it made me extremely proud.
Yeah, I know that, though that's really fun. So I think that I don't know what our timing in
Yeah, let's
here is,
ask if
but
there's any more questions coming from the group. I know Amy, Stephanie, Lisa, Don. Welcome, Don. Good to have you back. And Lisa, I know you've been on a lot of these calls as well, not as necessarily a practice, but you work with a lot of them. What questions do you all have?
I can simulate a little bit. Amy, tell me a little bit about your practice. Maybe then I can figure out what question I'm going to ask you. I shocked her.
I don't know if Amy's connected to audio with us
Okay,
this
okay, good.
afternoon.
Okay.
Okay. Stephanie, I'm going right down the list so everybody can kind of duck here. Tell me a little bit about your premium practice that you have.
Well, currently we have five surgeons, and you have some variance in personalities, right? So you have some doctors that are just they aren't super on board with the upgrades. They only push them if they really feel like the patient is interested. And then you have others that are very interested in the premium. So, when you have a mixed bunch like that, how do you kind of get to that premium status when your doctors aren't really of the same frame of mind, so to speak?
Hey, great question, Stephanie. And now's a very good time, knowing that everybody's going to lose $55 starting January 1st of next year. And the one thing is when we look at this 11% cut that we're getting, and a lot of doctors don't really understand the math on this, is most practices are running about a 70% overhead. Okay. And if you look at 11% decrease in your gross revenue on standard cataract surgery, that means you're going to have a 37% decrease in your take home pay per cataract. And all of a sudden that gets their attention. And then you can say, do you think it's going to get better in 2028? No, it's going to get worse again. So premium is the answer to the practice growth and being able to pay good wages and everything else. So I would talk to your lead people that are going to do this. This is a good practice discussion you should have because if you think about it, just think about those people that if they do more premium, the revenue that comes in, which means the staff can get paid well. And, there's just a whole lot of things that go along with it. And I can tell you, I've grown up with lots of practice like that, and people have their individuals, but now the surgeons are quite interested. Getting $466 for a cataract procedure, is almost not worth going to the operating room. I mean, once you pay your overhead, and also remember the patient's got to pay out of pocket for the premium, as Matt said, for the deductibles anyway. So this is a good thing for visiting some of the practices that have done this. All of the group practices, any of them that have more than three, have the same issue as they have the people that don't want to talk to the patient, they don't want to do the sales part of it. But it is the gift that we were given in 2005 by CMS that we can charge extra for premium surgery. And we need to take advantage of it for our staff, for our patients. If we're not doing premium surgery, you're not doing the highest quality surgery that there is, because we're not giving them, the best vision possible. And that's what they came in for. It's all, as we said before, is the bottleneck is at the surgeon level, and so we need to break through. And I hate to see the decrease in payment because it's totally unfair, but it's not going to get any better. And now it's critical when we're getting a 37% cut in your take home pay every cataract you do, if you're not doing premium. That makes sense, Stephanie?
Yes, that's a great insight there.
That's right. And summary is they may not have been super interested before, but they're about to be.
That's right.
And the good news is the technology's never been better. There's really no reason to be on the sidelines anymore. These technologies deliver in a way they haven't in the past. And, they just incrementally better all the time. Any other questions for our discussion? I think what we're going to do is we've had these notes up here for a minute. Dr. Durrie, I'm going to also just promote our session next week, Power of the Educated Patient. Talk about a segue. Our friend Chris
Perfect.
Soul is going to be speaking next week from Navigate. Navigate is working with, I think, 50 plus practices now. The patient schedules. They call in either referred by their optometrist or on their own. Between when they schedule with the front desk person or the phone person and when they actually come in for their consultation, the team at Navigate calls them and pre-educates them on their options. And it's a real turnkey approach to get patients educated about what they're going to experience and also about their important options to consider. They're helping practices increase, on average between 11 and to 12%. So from 21 to 33%, for example. So that's more like 50% depending on how you're doing the math. But it'll be a great session, and they've got a lot of great examples to share from that. And then we want you to just keep coming back, invite your colleagues and friends. Surprising to see the small group today, but I know it's getting back to school time. But we'll continue to get those, get information to folks as they need them and share best practices. Dr. Durrie, thank you so much for joining us. I hope to have you back soon.
Yeah, anytime. I think this is a great forum, and the fact that all these things can get recorded and stored and passed around just makes it real valuable. One thing I'd like to put in a second plug for Navigate, because they can modify their system and for what fits for your practice. So it's not a one size fit all. And I think it's a great program. And I've heard Chris speak about it, and I'm strongly in favor.
That's awesome. Thanks, Dr. Durrie. Have a great rest of your day. Glad to hear you were with your grandsons on the golf course today. What a good day to celebrate.
It's been great, and
Yep,
great to see everybody, and let's keep going premium.
that's right.